Hello and welcome to HipCast, the podcast here to improve hip fracture care. My name is Dr. Neve Ramsey, Research Assistant at the Australian and New Zealand Hip Fracture Registry. Before we begin, I'd like to acknowledge the Gadigal people of the Eora Nation as the traditional custodians of the lands we live and work on, and pay my respects to elders past, present and emerging. On today's podcast, we have a panel of Australian and New Zealand health experts to discuss the challenges and triumphs of multidisciplinary care for hip fracture patients. With us today, we have some of the members of the acute care team from Orange General Hospital. So we have Polain, Rehabilitation Clinical Nurse Consultant, Josie Lowe, Dietitian, Upson, Physiotherapist. And we also have Baxter, Physiotherapist from Princess Alexandra Hospital in Brisbane, Queensland, as well as Dr. Sarah Hurring, Geriatrician working in orthopaedic rehabilitation at Burwood Hospital in New Zealand. So welcome everybody, thanks for being here. To begin, Orange, I might ask you, can you tell us a bit about the structure of your multidisciplinary care team and how you think that this supports effective care for hip fracture patients?
Yes, certainly. It's Kate, the nurse. We started about 10 years ago with some funding that two of the rehab positions secured for us. And our predominant role is to in-reach to fragility fractures, the ortho-geri patient. We do pick up other fragility fractures, not just fractured hips, but predominantly they're fractured hips. And we have a senior team of clinicians that had a background in rehab because they felt that was an important aspect of the care. We started with a very full team, lost some funding 4 years in. So now we sit with a senior dietitian part-time, a senior physio, occupational therapist, and some speech pathology and social work that we grab and refer to if we need. We also have an allied health assistant that works with us and myself. And we work closely with a rehab physician who sees all the patients post-surgery, and very, very fortunately for the last couple of years with the geriatrician who is part-time but sees all our fractured hip patients. And I think the factors that we feel support really good multidisciplinary care for this cohort of patients is continued consistent professional relationships with our colleagues, so that we're never seen to be a pillar of brilliantness, which we are, and you know, won't dive in and help our colleagues. We've always been really, really mindful of that, and we meet with them every morning up on the surgical orthopaedic ward. So there's a lot of respect, I think, associated with the team. And also really good information. We case conference all our patients twice a week, and we often refer to that in the medical records, and just really clear, consistent communication, I would think. Josie, do you want to add something to that?
Well, I think from my perspective that the fact that our team sits together with a representative from each discipline, and that's really our home team, but we also, with our disciplines, have a strong link to the discipline department. And I think that's just worked really well. It's had some issues along the way, but we've been able to work on them. And I think the fact that we, you know, even physically our office space is together as a multidisciplinary team, I think that is a really important thing. So we just, you know, continually updating each other about what's going on during the day, about patients and so on.
Yeah. No, absolutely, because I think a lot of the time that is the challenge when you've got teams spread all over the hospital to communicate about different aspects of patient care when it is often so rapid and changing. Sarah, how does that differ to, or how is it similar to your health network?
Yeah, so in Christchurch, which is the main facility, we have quite a different setup. So we have a relatively big service. So we have over 450 hip fractures a year. So we have an acute part to our ortho medicine service based at Christchurch Hospital, and a 20-bed orthopedic rehab ward based at Burwood Hospital. The teams have been in existence for a very long time, and we're fortunate in that we are based pretty much ward based. We have a very comprehensive sort of allied health team with access to speech language therapist and as needed. And in our rehab ward, close interaction with the fracture liaison nurse. So we've effectively got two teams. So there's the acute team and then there's a rehab team. And those are based at different sites, but the geriatricians work across both those services. And I guess we are the ones who provide quite a lot of the link with that. We see all patients over 65 under the orthopedic service. And I agree entirely that I think members of the team respecting each other's ability and skill set and trying to understand the role that everyone plays is really important. And that needs really good communication with the teams and their patients and their family. That happens a little differently in the acute setting, as you might imagine, than the rehab setting, but we still try and do that as much as we can. So yeah, we've got quite a different model to you in Orange.
And Brett, what about you? What about you in Brisbane? What's your workplace looking like?
Thanks, Steve. So I guess some similarities and some differences. I'm based in the acute orthopedic wards, but we also have on-site rehabilitation here at the Princess Alexandra as well. Team-wise, I guess a couple of differences. We have a designated orthopedic PHO who's responsible for the neck of female patient population.
I'm sorry, is a PHO the doctor in Queensland?
Yeah, that's right.
Yeah.
So one of the house officers, principal house officer. We've got
Sorry, what is a PHO, Brad? Sorry to interrupt. What is a PHO?
So yeah, it's one of our house officers, principal house officer, one of our medical staff.
I'm not familiar with that term.
Like a JMO.
I think it's like a resident. Yeah.
Okay.
Yeah, sure. Thank you.
Yeah.
Yeah, that's okay. We've also got a NOF nurse position, so a CNC who's designated to managing the neck of female patients who are admitted, as well as an osteoporosis nurse practitioner position who's obviously vital for the long-term management of these patients. It's a combined orthopedic geriatric service, so an ortho-geriatric service that we have with a consultant, an advanced trainee registrar, and then also that orthopedic resident who's a part of that team as well. I think the key, really is that we've got a couple of leaders, which are probably the NOF nurse position and the ortho-geriatric consultant and advanced trainee. But those people who lead the service have a very strong respect for the role of the other members of the team. So I think a combination of strong leadership, but also respect for the role played by the other members has meant that we've been getting some very good results from the management of these patients with neck of femur fractures.
Definitely. Yeah, I think that's the needed balance in any team. What would you say the challenges are, Brett, in your team with the multiple different teams involved?
I guess challenges are we all have our other roles as well. So it's the physiotherapist on the ward, the occupational therapist on the ward, the medical staff, managing patients outside of the neck of femur group, and the fact that because we are all busy, I think we need to make sure that we have scheduled times to catch up with each other. And I heard Orange say that twice a week case conference, which is a fabulous model. We sort of meet on a weekly basis. But it's that combination of formal discussion in that case conference, but then also the ability to have those informal discussions when we see each other on the ward as well. So I think a certain amount of structure within the system to allow those formal discussions to happen, but then because of that respect for each other's roles, because of the approachability of the more senior members of the team, it means that those more informal discussions can happen as required also.
Yes, definitely a very important part of a functional team. And Sarah, I can imagine one of the challenges for your team across the health network is the two different sites, would you say? Or what do you find challenging working with multiple different people across multiple different sites?
Yeah, there are a lot of people involved. I guess I've been fortunate because I've been here for so long that actually I know everybody pretty well, and that is really important, I think, for building those relationships. And we have a fairly stable workforce. One of the issues we're grappling with currently is just some differing priorities. So the acute hospital is busy, and there's a real focus on trying to get people through the system. Whereas in the rehabilitation area, we're really trying to optimize people's function and give them the best chance of having a successful discharge. And so that's quite a tension at the moment. So balancing sort of patient flow for the system versus function for the patient. So I think those will be ongoing conversations. I think particularly in the rehab setting, we run into difficulties if team members have differing levels of risk. So certainly having a team that's fairly pragmatic and able to problem solve challenges is much more effective when there aren't members of the team who are trying to get everything perfect, because nobody really lives in a perfect world, and a hospital environment's clearly very different from living in the community. So from time to time, those sorts of challenges come up. But I agree with Brett that having strong leadership and driving the culture is really important. In my setting, it's commonly the charge nurse manager, or nurse unit manager is another term in Australia. But I've also seen very proactive senior therapists be able to really lead that team and drive the program for the patient. And that I've seen working really well too.
Sarah raises a really important point there, which is rehabilitation services are a finite resource. And so facilities, whilst it's, flow is key now to the hospital, large facilities, there needs to be an alternative strategy. So rehab shouldn't just be seen as a way to get patients out of the acute facility. So there needs to be an alternate pathway for those patients who don't need acute care any longer, but also aren't appropriate for rehabilitation. And if you fill your rehabilitation unit up with inappropriate patients, before you know it, you're not getting the patients in there. So I think, the acute staff having an understanding of that finite resource, working with the rehabilitation team to ensure that we get the most appropriate patients into the rehabilitation facility. I think that's a real key to the management of these patients.
Definitely. It sounds like, and I've heard it a few times, and even in this talk, knowing the roles and understanding what each person plays in the hip fracture patient's journey is really important. Orange, so I just wanted to hear your thoughts on the challenges that you face in your department.
Okay, so I think Sarah and Brett both made some really valuable points on the connection between rehabilitation and acute care. The stresses of an acute hospital. Last week we went into code red and we had to move patients, and I personally think that's one of the most important role I have, because I'm asked to all the meetings that only managers go to, even though I'm not one. And I'm constantly, very gently saying, these patients aren't ready to move, or we are very, very fortunate to have close relations with small facilities, the three very close to us, who take and nurture our patients who aren't ready for rehab, don't want rehab, can't go home, and let us with their clinicians help sort them out. And that has over the last 10 years evolved into a really valuable commodity. And we totally respect them for the work they do in those facilities. But I do find, as Brett said, constantly at the daily bed meetings up on the wards, I'm constantly validating the role that is rehab and those patients that need it versus they just need a little bit more physio or OT or something. So I think to be part of your acute team's meetings daily is really, really important. And to promote you know, well-being and to promote rehab, because, you know, a lot of people just think it's, you know, we just send these patients there and they'll sort all the problems out. So educating very gently the acute staff just very regularly makes a big difference.
Definitely. And you raise a good point about your daily ward meetings.
Yeah.
Can you tell us a bit about, so it seems you've got this bi-weekly meeting and then the daily meetings. Can you tell us a bit about that routine?
Yeah, that was confusing. The subacute team with the rehab physician and a pharmacist, and they're gold, by the way, and the JMOs, the ortho JMOs, if they have time, we welcome them. Twice a week, we go through all the fragility fractures, all the patients we're in-reaching to, because it's an in-reach model. And then on a daily basis, one of the senior physios years ago had a brilliant idea that we should actually all get together, the charge of shift on the orthopaedic ward, physio, OT, social work, anyone that can, and one of my team, just to quickly go through the patients and any discharge planning issues, any rehab, let's get to rehab issues. So that happens on the acute ward with the acute teams, and it's more about them saying, are you guys helping out with this patient that's a fractured hip? So it's about communication and respect. And then if they're busy on the wards, Joe, the physio, or Josie, the dietitian, or the OT will say, hey, I can help out with those patients. So we don't just stick to fragility fractures, but it gives them a window into what we think the importance of managing these fragility fractures is, and to us saying, hey, we've got time, let's work together and sort out some of these other acute patients, because we work within a big regional facility and we can't be precious about keeping patients just to finish off stuff. We've got to, you know, work in with everyone to move the patients when it's appropriate. So we're a in person up on the ward every day, and the therapists on the team actually review and manage the patients. So even though we're collaborative management, the physio and the OT will actually treat the patients.
Fabulous. And Brett, what does it look like in your workplace? How do you make sure a good handover is provided on the ward?
Yes, over the years, we've tried a few different strategies, as I'm sure most facilities would have. There's always a lot of tinkering going on, a little bit of playing with what that looks like. We've tried to look at a few different ways, and I guess there's the NOF patient population group, but then there's the other orthopedic patients as well. So we have a couple of board rounds, and I guess the idea there is to be able to move through the patients quickly, but also, I guess, discuss any issues which we don't, you know, a discussion we don't want to have in front of the patients. So it's helpful to have that. We also have a daily ortho-geriatric round that happens. So that's the training registrar, and the orthopedic medical junior medical staff, as well as the NOF nurse as well. So they see the patients on a daily basis. And that's, you know, really about the medical care of these patients, ensuring that it's optimised, ensuring that appropriate referrals have been made, ensuring that the right people are involved in the care of that patient. And then the orthopaedic team as a whole also does a weekly round at the bedside as well. I guess the idea there is to be involving the patient in discussions that are occurring. That's generally around from the point of view of making sure, again, the people who should be involved in the care are. Issues such as discharge destination. So is it a rehab track that we're going down with this particular patient, or is it discharge to home with support services in place? And then discussion around the patient's expectations of length of stay, so estimated discharge date, and the ability of staff to then input into that to ensure that you know, those expectations are realistic, and we're all on the same page from where we're headed and how long we think it will take us to get there as well. So I think that's sort of multifaceted, you know, a couple of different approaches. On the weekly round, we also identify any sort of complex patients who we think might need further discussion around those issues, and we'll then set a bit of time aside for a more in-depth multidisciplinary discussion for those particular patients. So I guess it's a combination of a lot of different strategies trying to make sure that communication happens appropriately.
Yeah, definitely.
Always challenging.
Always challenging and never as simple as you always set up for it to be, I'm sure. Sarah, I'd be interested to hear firstly how handover occurs at Burwood there, and then is it Canterbury that's your acute hospital?
Christchurch.
Christchurch that's your acute hospital. How do you get the handover between sites?
Yeah, so the communication we have is pretty similar to how Brett has outlined works where he is. Because there are pros and cons of being on different sites, but I guess one of the things is that because they are officially sort of discharging from one hospital and readmitting to another hospital, then we get all of this sort of standard documentation that's required at discharge. So the medical staff do a transfer summary and the nurses do an electronic handover. And where patients are a bit more complex, the geriatric medicine team at Christchurch on the acute wards, who have been seeing the patients daily, will liaise with the team that they're coming to at Burwood. The only other thing that we've been trialling on the rehab ward is some afternoon huddles, which are a touch point with often the nurse in charge and the key allied health members to really see, are we on track for things tomorrow? So particularly discharges, and to try and avoid those known about but not openly communicated issues that might have come up during the day, really trying to avoid the surprises on the morning of discharge that actually it can't go ahead. So that's been quite useful, just to touch base on some key patients each day.
Absolutely. No, it's really interesting to see how everybody else approaches it across different networks and finds their way of doing things. So, I mean, we're all probably aware of this, but unlike most jobs that run Monday to Friday, patients don't only come in business hours. So I wanted to hear about how over the weekend, what kind of services are available for hip fracture patients, and do you think this has an impact on patient outcomes? So perhaps Sarah, I'll start with you.
Yeah, so we've been really fortunate in recent years to establish the ability for a geriatric medicine registrar to be working in the acute orthopedic wards in the weekend, so Saturday, Sunday, sort of 8 till 4, so day shift. And their primary focus is on reviewing the new hip fracture patients and reviewing any acute medical issues. So those things are being managed on an almost 7-day-a-week basis. And so that allows, I think, acute medical issues to be kept on top of. People are sorted out, so there's no reason for medical delay for their surgery. And some of the registrars who are experienced in the job can also start to signal what the transfer plan might be and and whether they're likely to need rehab or not. So that's been really useful. From an allied health point of view, there is physio, so targeted physiotherapy assistance reviews in the weekend. That also happens on the rehab ward. But that's really, it's not as comprehensive, I guess, as we would like it. And I think certainly in the rehab setting, you definitely notice a difference between what's happening on the ward during the week and what happens in the weekend. Every one of these sorts of takes a chance to take a breath, which for some patients is fine, but of course for others it's not. So it's trying to encourage the sorts of things that happen on a Monday to Friday to flow over into the weekend. One of the things we've been really targeting in our whole rehab service is the concept of, at least 3 walks a day. And I've seen the nurses are starting to take much more control of that. So nurse-led, assisted mobility, so that even though there might not be a physiotherapist there, patients are getting opportunity to walk or try to walk, throughout the weekend.
Yeah, that's a fabulous idea, just reinforcing the 3 walks a day. I haven't seen that before. That's a good idea. Orange, what about you? What happens on the weekend there?
Yeah, I'll let Jo talk about the allied health, but can I just say we're lucky enough to have, because we fought for it before Dr. Butler came, we asked and pleaded with the medical staff, the VMOs, to have one of their registrars, not on call, but that we could ring for the fractured hip patients that might become unwell or needed reviewing, because the orthopods just said, you know, we do the bones, you do the rest. So we do have acute medical cover if we need it. And just a point, sorry, about the rehab allied health. We were part of a AROC study years ago about the if we increased therapy on the weekends, would the length of stay shorten and the outcomes improve? And I think I don't know that we finished putting our information in, but I think they did prove that it does make a difference, that 7 day a week. And part of my role in rehab, but also now in the wards, is to promote the nurses to take over and walk with the patients, do all that incidental stuff. You don't need a senior physio to continually walk a patient out to the toilet and back again safely. Like, once they've been seen and a plan's in place, I see part of my role is empowering the nurses to get them moving and keep them moving, especially on the weekend, as you said. But Jo's much more knowledgeable about the allied health side of things.
Yeah, so in terms of allied health, we only have physio coverage over the weekend, and there's one physio for the whole hospital, so it is quite limited. So fractured hip patients are seen if they're a day one post-op, and so that's through referral and discussion with the teams on the ward, and also whoever we've put on the weekend on a Friday, or the weekend list on a Friday, sorry. So they will be seen day one, more for a mobility review, set them up with some exercises and get them out of bed. If they're deemed that they need physio on the Sunday as well by the weekend physio, they'll put them on the list again for the Sunday. But if it's a patient who I've been seeing throughout the week and they have a safe mobility plan that the nursing staff can reinforce and put in place over the weekend, they won't be seen by the weekend physio. Ideally, I've set them up with some sort of an exercise program that they can complete independently or with their family members, and put the onus back on them to progress themselves over the weekend in that regard. But yeah, the weekend service is limited, but there is a little bit of leeway, especially if a patient isn't progressing as much as we'd like and would benefit from weekend physio. We'll be able to put them on the list. Yeah, so that's what we've got here at Orange.
Yeah. Oh, yeah, sorry.
It's Josie speaking. The other thing that we just need to be a little bit proactive about is plans for over the weekend, and who might potentially be ready to transfer if there's bed pressure or not, and who, you know, we've talked with the teams about definitely need to stay until next week and that sort of thing. That can be an issue over the weekends, that sometimes patients have moved on a bit early.
Yeah, definitely.
So we've learned to be a bit devious, but we probably shouldn't go into that on air.
Yeah, no, it can be tricky, and being mindful, I think, of the weekend coming up is always really important. Brett, what about at Princess Alexandra? What's the weekend look like there?
Neve, so I guess some real similarities to the other sites. We've got weekend service from an allied health perspective, from the physiotherapist, the occupational therapist, and the speech pathologist. And I guess the weekend service is in the neck of femur patient population group. It's probably more directed towards those patients who are on a trajectory to discharge direct to home. But certainly similar to Orange, if a patient's day one post-surgery or early on in that sort of post-op recovery period, they can be seen by the physiotherapist. But the resources are probably a bit more directed towards those patients who have been deemed likely to discharge direct from the ward, and to sort of speed that process with the increased allied health input. But yeah, definitely reinforcing what the other guys have said, in that, you know, these issues around mobility, it's everyone's responsibility. You certainly don't need a physiotherapist there to be mobilising a patient. And if we all see it as our responsibility, then it happens a lot more often. It happens a lot more commonly. One of the questions that you had sent through to us in preparation for this meeting was around delirium. I think you know, things like routine. The guys mentioned before, sitting out for meals, the three walks a day. They're all about getting people back into a more normal routine. I think that's what we can help with.
Yeah, that's a definitely a take-home point, to stress that preventing delirium, the routine, and keeping people moving is so important for our hip fracture population. And yes, thanks, Brett. You're bringing us onto our last point of what are the aspects of delirium prevention that you would each stress that we need to be more mindful of from each of your clinical backgrounds.
I'm happy to go first. So
yeah, please.
Early mobility. I think in the elective lower limb arthroplasty population, we've had this real move from, when I first started in physio, patients rested in bed for 4 days after a total hip replacement. Now it's the afternoon of the operation that they're getting up and moving. So some of those principles we can also move across to the trauma patient and the fractured neck femur patient. So early mobility, routine, sitting out of bed for meals. I think the important thing here though as well is that it's not sitting for too long. So what we don't want is for the patient to be gotten out of bed for breakfast and then sit for a 6-hour period. Okay, we all know the issues that leads to with pressure injuries, and a whole, it's about changes of position, regular changes of position. So sitting up for an appropriate period of time, making sure that there's appropriate equipment available for that to happen. We had to have a big project here to get appropriate sit out of bed chairs for the patient population group, and those sort of barriers don't need to preventing this stuff from happening. Incidental, so walking to the toilet, walking to the shower. If I could get rid of mobile commodes, I would, but it's not an issue. But the number of times you see patients who are able to walk whizzing past you on a shower chair, and just that little call out, oh, that patient's right to get up on a roll out, I'll give you a hand with that next time, so we make sure it happens. But yeah, I guess they're all mobility based, but that's what you'd expect from a physiotherapist, wouldn't you?
Yes, but I think they're all really simple things that can be implemented that do make a big difference. Sarah, what do you think we could all be a bit more mindful of for delirium prevention?
So I entirely agree with the trying to get back into a normal routine. So I think something that is often overlooked is trying to optimize sleep for patients. So it's very hard to sleep in a hospital. And I think, again, it's a simple thing, but trying to optimize the environment at night. So thinking about, what's the lighting like? What's the noise from the night staff who aren't there to sleep but are there to work, and then being mindful, thinking around whether observations need to be done in the middle of the night, the medical team looking at timing of medication. So often antibiotics are put in a routine sort of 4 or 6 hourly pattern without a lot of thought given to the interruption of the patient overnight. So I think people being mindful. So we all know what it's like when we haven't had much of a sleep. So I think if you're already starting to be in a bit of a brain fog or feeling a bit scrambled, then having a good sleep is really going to help. So I think that's something that's often overlooked but very easy to do, I think. I guess I should talk about at least one medical aspect, and I think thinking about appropriate pain relief, because people won't get up and walk if they're sore, and particularly patients who are already cognitively impaired or developed a delirium. I often see patients who have still got as required dosing of medications, and they aren't likely to be able to ask for it. And so I've just heard about a patient today who's got dementia and isn't walking very well, but both she and the nurses said that pain wasn't an issue, but actually the physiotherapist has said, no, that's absolutely impacting on her recovery. So I almost always will give these types of patients, regular pain relief so that we know it's not pain impacting on their mobility, which I agree entirely with Brett. We need to get them moving to recover.
Yeah, thank you. Some really, again, simple points to take home and to implement that can make a big difference. Orange, we're really lucky that we've got 3 of you there from all different disciplines. So it'd be interesting to hear what do you think we can do to optimise delirium prevention?
Yeah, look, it's Kate, and ditto to everything that Brett and Sarah have said. And I think especially being a nurse and an old nurse, sometimes I despair because nurses do night duty, and to be honest, it nearly sends you mad, especially when you do 6 weeks of it in one stint. And you would think that they'd think, oh golly, sleep of a night time when it's dark is important, and start implementing those really simple things like sitting out of bed, pain relief, good sleep. Because, I mean, we all know how it sends us mad when we just haven't slept. But I think one of the things that I feel I need to push, mainly because it's predominantly with the nursing section, is we're very good because we have these, you know, everyone checks on it. We're very good at identifying the risk of a delirium because we do all these little frats and drats as they come into hospital. But one thing I think we're still not good at is thinking, oh, the behaviour's changing, let's do something about it. We often wait, hoping it'll go away. And I think we really need to be more mindful of not just identifying the risk of delirium, but putting strategies in place early so that the full-scale hypo or hypoactive delirium doesn't happen, because it can be quite deadly, as we all know. But Josie, do you want to?
So just being in touch with families a lot, I suppose. Well, when this team was set up, we were sort of an additional layer of service, and so we did have extra time and were able to make sure that we connected with family to check if this was the person's normal behaviour or not, and making sure that we support oral intake, you know, particularly if people are drowsy, trying to encourage them to still be, you know, prompted to eat and so on, and tracking bowel actions because that can so often get lost in the mass of paperwork and in the changeover of staff and so on, and we don't have a little alert going, oh, day 3, and I do check electrolytes as well. And I think that's something that can impact on delirium, and we don't always have the right bloods being taken to pick up on those changes.
From Joe, physio-wise, I definitely ditto Sarah and Brett, and also the girls here. In terms of pain relief is a huge thing that I see issues with, especially when you've got little 85-year-old Doris who's already got a cognitive impairment and they've charted them PRN endone for day 1 mobility. I straight up say, oh, let's have a think about this and chat with the acute pain service. We've got a great APS service here, and they can often do a pain block on day 1. So rather than giving them opioids, we can get them moving without that, which is really good. But as Josie said, discussion with the family and telling the family to actually notify us of any changes that they notice, because they know the patient best. We know them for a few days and we can detect changes over a few days, but they definitely know the patient best in that regard. But also as a physio, seeing my role, especially as Brett was saying, of that daily routine and getting your patient to the bathroom, into the shower, and getting them opening their bowels. Yeah, that's such an important factor. And yeah, I think Kate's had a huge influence on me in my practice in terms of understanding how important bowels are and getting excited over bowels, getting moving, but also raising concern when they're not and stamping your feet and saying, this isn't good enough, this needs to happen, because they won't get moving and they'll get more confused. So yeah, I guess for us it's a very holistic look at it and interdisciplinary.
And we've even got a tick box on our case conference template to talk about our bladder and bowel management.
It's so important, and it's definitely something I never thought I'd be so excited about, but working in the hospital, it is an exciting thing.
It is.
Well, thank you everyone for your time today. I might just sum it up a bit and say, so I think what we've discussed today is that communication and mutual respect, not only between teams, but also with the patient and their family, are really key to achieving optimal results for your patients. In terms of simple things that we can all do that can help optimize this with a multidisciplinary team is, pushing for that mobility, making sure pain's controlled, not forgetting about sleep, and as we mentioned, keeping your eye on the bladder and bowels. They're all really simple things, but they do make a huge difference. So thank you everyone for your time today.